Some of the key management issues that I took away from the recent Cure SMA meeting has to do with reinforcing the differences between two SMN2 copies and three SMN2 copy numbers in terms of their outcome that was presented with the sprint data, reinforcing that the two groups are very different and need to be managed differently with newborn screening. Other data that was presented was novel topaz data with the apitegromab, the anti-myostatin inhibitor, showing benefit, especially in children who are treated early. That 2 to 5 age group had the best response, not so much in the older age groups. The pediatric component that was also novel is the recent rainbow fish data, which is the pre-symptomatic risdiplam trial that is underway. And though there are a few patients just yet in that smaller SMN2 copy number of two, they were very promising and reassuring, and we need to wait for the completion of the study for a better idea of the totality of the response to risdiplam in pre-symptomatic children, as it's not yet approved for use under 2 months of age. And there were a few studies in adults with nusinersen showing its benefit. Again, they're not controlled clinical trials, but they were well executed and showed some response, obviously not as robust a response as you would expect, as we saw in the younger children in the Cherish study, but still reassuring in a way that nusinersen can be helpful in an adult population. There was interesting data presented from the Restored database, which is the newborn screening and Onasemnogene-treated patients that are part of the Cure SMA database, collecting um, information on symptomatic and on pre-symptomatic infants treated with onasemnogene, and showing improvement with patients who were treated, um, and contrasting that with children who were treated symptomatically, which obviously there was a big divide, showing that pre-symptomatic treatment is associated with a much better outcome than when there is symptomatic treatment, because time is motor neuron, as we are all aware of. There was also data presented on the DEVOTE study, which is the high dose, less frequent nusinersen intrathecal administration. And there was a small group that was presented with the initial or preliminary dose escalation that had some safety profile presented, but there still isn't much in the way of outcome data. It's in early stages, and we are looking forward to the results of this study when it becomes available. The musculoskeletal section was interesting to see the benefit of the surgeries presented, especially long term, showing its efficacy and sustained benefit over time. What was a bit surprising to me was information showing that the bracing, the TLSO, the thoracolumbar sacral orthosis, did not seem to prevent progression of curvatures as much as improve the posture of children. So, in any event, it is a good thing to use to provide a better position for children, and that affected children of most ages. New data presented at the Cure SMA meeting relating to nusinersen um, affected a cross section of patients, from the pre-symptomatic nurture children, in which there was reports of bulbar function and swallowing issues. And what was noted is that they preserved swallowing. The dysphagia concerns were seen in a subset of the SMN2 copy number of 2, as opposed to children with SMN2 copy number of 3 who had no such concerns. And this has been a recurrent theme that we've seen with regards to motor outcome, and now we're seeing with regards to the oropharyngeal function that there's a distinction between copy number of 2 and copy number of 3, again reinforcing that the two are not similar, and early treatment of the SMN2 copy numbers has to be quite expeditious so that you don't lose motor neurons, because that's what's predicating these differences in these groups. The SHINE study presentation that I found novel was more on the 6-minute walk test that continued to show maintenance of function and some improvement in 6-minute walk test distant walk. And that's in a very small subset of the CS2, CS12 open label study. Because there were no such patients included in the CHERISH study, which, as you all know, is only for SMA type 2 patients who were included. Another nusinersen-based trial and the Cure SMA meeting that was presented is the DEVOTE study. And this is a multi-part dose escalation study using higher doses of nusinersen than previously have been used. Um, the part A that was presented is a safety and tolerability study, and it was using 3 doses of 28 milligrams of nusinersen as a loading dose at day 1, 15, and 29, followed by a maintenance thereafter. So, the main take home message of this presentation is safety and tolerability of this part A of the DEVOTE study. And what that found is that there were no serious adverse events and no adverse events that were related to the study drug, because nusinersen was found to be safe. There was, however, about 24% rate of lumbar punctures or related to the intrathecal process side effects, which are a very common finding and are self-limited and not unexpected. So, of the totality of presentations of the nusinersen studies, there were no earth shattering presentations that would necessarily alter our management of patients currently. I think one presentation that I found helpful was the Nurture study showing us bulbar puncture in pre-symptomatic patients with nusinersen that showed that it was preserved and that the gradient that is seen with nusinersen does not seem to affect um, bulbar function in pre-symptomatic patients who were treated, and that most of the findings were related primarily to SMN2 copy number. With regards to adult, there was addition to the literature of its efficacy in the adult population, which had not been quite as robust in U.S. cohorts. There has always been an indication for treatment with nusinersen in patients of all ages, so it doesn't really change our management. It just reinforces of its utility in all age groups from pre-symptomatic to adulthood. There were nice studies from 2 different groups with regards to SMA in adult patients treated with nusinersen. And they did show improvement in function. In some motor function, they show in the ROM, the revised upper limb module. I think that's where it was more noticeable in these more advanced patients. There was a decline in respiratory function notice. It was a small percentage, but that did not include increase, and that may be a phenomenon that can be seen across different studies in the adult population. A more granular approach to the adult treated patients with nusinersen for more difficult patients administers it via cervical guidant procedures. And there were 25 patients who presented it. Um, and there was a subset of patients, about a third, who declined on the ambulatory patients who declined on the 6-minute walk test. And many of them had no change, but again, in that population, stability of function is something that is an improvement to the natural history of the study, which is a decline over time. So again, in the more severe patients, you don't expect a huge response, but this is in ambulatory patients who are a bit uh, more functional, of course, because of their ambulatory status. And to me, that was striking, that the contrast with the German study that showed frank improvement across all modalities in the population that they followed. It was a large multi-site population, but perhaps that group was a bit uh, stronger than the population enrolled by Dr. Bakri, who seems to be a more real-world patients with a wide range of severity who might not have improved as much as the patients who were enrolled in that German study. The data related to Onasemnogene apaparvovec XIOI that was presented at the recent Cure SMA study related primarily to the pre-symptomatic study SPRINT, as well as some data on the long-term studies on Onasemnogene apaparvovec. So let's start with the SPRINT data. And Dr. Strauss presented the data showing excellent um, developmental outcome in the children who were treated as part of the pre-symptomatic cohort. The main distinction, and what's been seen as well as in nurture, is that the SMN2 copy number of 3 were in the normal range in all developmental milestones, whereas for the children who were enrolled with SMN2 copy number of 2, had a portion of children who delayed a bit and might have attained the ability to walk later outside of their milestones. But the children had no respiratory issues and had no swallowing issues, which by and large was a big departure of the natural history of SMA and reinforces the need for early treatment and how pre-symptomatic treatment can be associated with a normal to near normal outcome. The long-term study is a compilation of various gene transfer therapies, starting with the START study, the initial study, and the children are now about 5 years of age or older, as well as the various STRIVE studies, the ones in the US, Europe, and in the Pacific. Overall, I think my take home message was that there's durability to the gene transfer therapy, and that in the longest followed group, which is the START group, that you still saw an excellent outcome in these babies who are now kindergartners, if you will. That is important to confirm that there were no long term adverse effects that showed up over time that we should be concerned with, and that there was durability, and that they maintained the benefits that they had seen um, in the early part of the study. So finally, risdiplam uh, data presented at the Cure SMA that was novel included data on the rainbow fish study as well as in the jewelfish study. So let's start with the rainbow fish. A rainbow fish is the pre-symptomatic study with risdiplam that includes children under a certain age, I think it's 6 weeks, who have to be pre-symptomatic. And it is still enrolling patients, so this was very preliminary data. And what it found is that in the few patients that had been treated, that they had a favorable outcome and that there were no significant side effects. The data is still being collected, and final analysis will have to uh, wait until that final data comes out, but it looked very promising as an alternative for pre-symptomatic patients. The second new presentation was the jewelfish study, which is a study that I am very familiar with, and I presented during the meeting. And this is a large study. There are 174 patients in the study. The uniqueness of the jewelfish study is that it includes non naive patients. These are patients who have been treated with disease modifying therapies, and that includes two molecules that are no longer under study, which is the RG7800, the old moonfish study, and the alexithymine study, which is also not being pursued further. And then there's a substantial group of patients previously treated with nusinersen, as well as a smaller group of patients previously treated with onasemnogene apoparvovec, both intravenous and intrathecal. And that's the smaller of the group and the more recently who have been followed. It was mostly a safety and tolerability study to show that prior treatment with these medications was safe and that risdiplam can be added or followed without any undue safety concerns. So it's primarily a safety and tolerability study. So with the focus on that, what was found is that there were no serious adverse events that were related to the medication, risdiplam, and that there were no withdrawal of medication due to side effects to risdiplam. And that's the take home message. And when you look at the onasemnogene apoparvovec treated children, they had the same safety profile as did the entire cohort. So overall, nothing related to the medication. Certainly none of the preclinical findings that had been reported were found in any patient. With regards to the AEs that were noted, these were mostly related to the underlying disease, SMA, and mostly respiratory issues were the most serious ones. We also did an efficacy assessment as a um, exploratory assessment. Exploratory because it's not the primary reason for the study, because these were patients who ordinarily would be excluded from a clinical trial. They were very advanced disease, with the majority of patients, except in the onasemnogene, having a Hammersmith uh, functional motor scale extended of less than 10, who had scoliosis, and a lot of them had severe scoliosis. So that impacts any study that shows improvement, because when they're end stage, it's less likely to be seen, and that's across the board. So, in with all of that in mind, we did find on the MFM32, which is the primary outcome measure that was used in the sunfish, and that shows over time more sensitivity to change, especially in these older groups, and has been found to decline over time in this population. So the fact that the study found stabilization of outcome, I thought that was an important finding, that despite the heterogeneity, the severity of the population, there was no progression of disease. We're going to continue the study until 24 months, and we'll have a complete analysis of all the data sets. We did not do subset analysis in this group, um, and just to note that children under 2 who are in the gene transfer therapy would not be included in this analysis, because children under age 2 can't participate in the MFM32. So those were the two related to risdiplam. The rainbow fish, which data will help confirm its utility and safety in the under 2 month population, and then the safety and tolerability from prior treatments that was found to be safe and quite tolerated in this population. Importantly, only 5% of the patients withdrew from the study over time, which is a very small proportion, and none of the patients in the gene transfer therapy withdrew from the study. The management of patients who have a decline in function or a perceived lack of efficacy is often something that clinicians are faced with. And for many of the patients who were in the nusinersen group, that was one of the main reasons, aside from access. So for those patients who had tolerability concerns about the intrathecal injection, or who had perception that there was a lack or loss of efficacy, this switch over to risdiplam would be a viable option, as was noted here, that there was at least stability, that patients would keep whatever benefit they might have had and certainly not show further decline. So I think it adds the possibility as a viable alternative when nusinersen is considered not to be the best agent in the eyes of the patient or of the clinician to switch over. With regards to risdiplam in the pre-symptomatic, we have to wait for the data to be accrued, but it does appear to be safe and tolerable, and some efficacy was seen, so it may be an option in the future to be considered for that newborn screening patient who is interested in treatment and may not be interested in the other two agents that are currently in use, either because biological side effects are of concern or access and the procedure of intrathecal injection may be of concern to the parents. But that's still in the future because that study has not been completed or approved for use under 2 months of age. One of the more novel therapeutic agents presented during the Cure SMA study is from the Topaz study presented by Dr. Crawford regarding an anti-myostatin inhibitor, which is now a name called apitegromab. And just a little bit of background for those who are unfamiliar with it. Myostatin is a muscle regulator and it prevents overgrowth. So there are, for example, in nature, animals who are missing the myostatin, and they have Herculean muscles with muscle overgrowth. What this agent does is act on a different system, and the study includes nusinersen, which acts on SMN protein elevation through the SMN2 splicing modulator on the SMN2 gene, combined with a target on muscle, which is with an intravenous monthly injection with apitegromab. This combination therapy should work synergistically, giving a more robust response, theoretically, than you would expect with treatment with either agent in isolation. So let's look at the strata of patients who've been treated with combination therapy, the nusinersen apitegromab group. So in the younger group, and that is the under age 5 who have been treated with nusinersen under age 5 who are receiving apitegromab, there was the most robust response, and it was 7.1 points on the Hammersmith Functional Motor Scale Extended, which is a significant. We consider more than 3 points clinically meaningful. Just one point of caution to make in interpreting this robust response is that in the natural history study with type 2 SMA, these patients normally do improve in this age group as the developmental milestones progress more quickly than the disease progresses. So you do see in this period of time, in this age group, some improvement even without intervention. So that's just something to keep in mind. When you look at the second group, which is the group over 5 years of age who are non ambulatory, you see that there is not such a response to the combination therapy. It's actually quite meager. It is less than 1 point. When you look at the totality of the patients who in this subset, there was a sub hoc analysis showing that the younger patients maybe improved a bit more than the totality of this cohort, that's 5 to 21. But still, on the whole, the response of the combination therapy was not as robust as you would expect when it's given outside of the younger age groups. But overall, a strong finding, at least in the younger children. A novel approach study is looking at enhancement of the neuromuscular junction to improve fatigue in patients with SMA. It is known from prior studies that there appears to be a degree of neuromuscular junction failure in patients with SMA who have a greater decline to repetitive nerve stimulation, such as that seen with myasthenia gravis. So this study looked at pyridostigmine and its effect on endurance in patients with SMA, type 2 and type 3. And what they found was that pyridostigmine increased endurance, meaning it decreased fatigue. And there are two types of fatigue that are known. One is the subjective fatigue, and the other is the functional fatigue, the motor fatigue, which is the ability to do more during the same period of time. And this was a motor proficiency fatigability showing the greater endurance with pyridostigmine. This has applications for fatigue in SMA. The study did not show any improvement in motor function, but did improve endurance, which is a very common complaint in patients with SMA. So, for those patients where fatigue is a significant factor, the use of pyridostigmine, which is would be an off-label use, but clearly this is um, an FDA approved medication, may be something to consider that might alter the practice of clinicians in whom patients' fatigue is a significant complaint. The Cure SMA meeting has highlighted many of the wonderful advances that have occurred in treatment of SMA, the ones that are clinically approved, as well as potentially novel therapies that are in the pipeline with combination therapy targeting different sites, SMN modifying therapies plus muscle target, for example. Despite these advances, the access to therapy is not universal, and the speed of which we can identify the early identification, even in the United States, is not uniform, as not all states have newborn screening that is operational at present. Many have approved it, but it's still being processed. So that causes challenges to clinicians. One of the challenges with identification has to do with speed of access to SMA gene testing. In the United States, that has improved dramatically, and now we have access to those testings that are even free of charge with a rapid turnover so that treatment can begin expeditiously. That degree of access to the genetic testing is not universal. And in other parts of the world, especially parts of the world that aren't as industrialized, that may be quite difficult to achieve and can have to be done based on clinical situations, which is less than ideal and oftentimes not what is allowed to start with treatment. When we deal with newborn screening, there are differences with how fast the investigator is alerted and how fast they can access medication depending on the insurance, depending on where you are in the country, whether there's even insurance for that baby, and how fast that insurance is processed. And those delays can cause harm, especially in the SMN2 copy number. Later on, there are delays, even with symptomatic, in terms of being allowed to treat a child, for example, with risdiplam, who does not conform to what has been published in clinical trials. And that is oftentimes seen across the board. We see this with newer medications a little more so than with those that are established. Then it's a growing curve, at least in the US, with regards to um, a- the insurance companies having a familiarity with the medications that we are using. We still have difficulty with transitioning medications when we believe one medication may not be working as well, trying to get that second medication approved. And oftentimes that has proven quite difficult, even though there are big differences between two medications, and still you have to prove why you have to use the second medication. At an international level, it is more of a problem because oftentimes there is no access or timely access to specific medications. I know that it is increasingly being approved in, for example, South America and in Asia, but it is not uniform by any stretch of the imagination and is impossible to access in some countries. The hope is that it would be universally available newborn screening and that we are able to identify all children before they become symptomatic and treat them in a timely fashion. And then we wouldn't have to have this dichotomy between those identified presymptomatically who have a very bright future, as opposed to those treated symptomatically, which, depending on how advanced their disease is, are going to have greater burden to find recovery. And the other topic in that regard is with regards to gene transfer therapy. The gene transfer therapy is very effective when it's used early, and the younger they are, the better it works. In later, more symptomatic patients, it's not as effective and may even have higher side effects because the number of vector genomes that needs to be administered, which is weight based, is much greater, and the side effects greater as well, and the likelihood of improvement less easy to obtain. So early treatment in those cases is of the utmost importance. When it comes to newborn screening, I have made a big plea for people to take into consideration the nurture and the sprint data showing how those SMN2 copy numbers of 2 are a very different population who can't afford to wait days as opposed to the SMN2 copy number of 3. So it's important then to treat as early as you can, not delay at all. And if there's any specific item, laboratory test, for example, AAV9 titers or troponin elevations, or something that you would need to wait in order to administer, for example, a gene transfer therapy, that you should be proactive and offer a gap treatment. For example, now we have nusinersen, so a gap treatment of loading until the time where those side effects diminish, or if they don't diminish, then you can choose to switch to an oral medication that would be approved after 2 months of age. So, no delays, bridge with another medication if needed for those with two SMN2 copy numbers.